Drugs for treating diabetes and disordered glucose metabolism. At the end of this, students should be able to describe the actions of insulin on glucose storage, explain glucose hemostasis and glycemic control, differentiate between the glucose metabolic disorders, identify common anti-diabetic agents used in the management of type 1 and type 2 diabetes mellitus, summarize the recommendations for managing mild hypoglycemia, and administer glucagon for patients with severe hypoglycemia. Disorders of carbohydrate or glucose metabolism result from multiple etiologies, all of which are characterized by chronic hyperglycemia with disturbances of carbohydrate, fat, and protein metabolism that result from defects in insulin secretion, insulin action, or both. Diabetes, also called diabetes mellitus, is a spectrum of metabolic disorders arising from a myriad of pathogenic mechanisms, all resulting in hyperglycemia. Blood glucose, also known as sugar levels, reflect the differences between the amount of glucose released into the circulation by the liver and the amount of glucose removed by the blood into the body tissues. Energy metabolism is controlled by several hormones, including insulin, glucagon, epinephrine, growth hormone, and the glucocorticoids. Of these hormones, only insulin has the effect of lowering the blood glucose level. Insulin facilitates the transport of glucose into the body's cells and decreases the liver's production and release of glucose into the bloodstream. Insulin also has the effect of decreasing lipolysis and the use of fats as a fuel source. The pancreas is primarily in the hormone's control of blood glucose. The action of insulin on the glucose are as follows: to increase glucose transport into the skeletal muscles and adipose tissue, increase glycogen synthesis, and decrease gluconeogenesis. Serum insulin levels begin to rise within minutes after a meal, reaching a peak in approximately 3 to 5 minutes and then returning to base state levels within 3 hours. The most important diagnostic test for all types of diabetes is fasting blood glucose levels, or the blood glucose concentration after no caloric intake after 8 hours. Fasting glucose requirements are primarily provided by liver glycogen stores. The broad categories of glucose homeostasis are defined as follows. Normal glucose homeostasis is fasting blood glucose between 60 and 100 milligrams per deciliter. Eugoglycemia, normal postprandial glucose. These are levels of less than 140 milligrams per deciliter within 2 hours after a meal. Hypoglycemia is blood glucose levels of less than 70 milligrams per deciliter. And hyperglycemia is excessive blood glucose of greater than 200 milligrams per deciliter. After you've eaten, the concentration of glucose in your blood rises. When it goes too high, the pancreas releases insulin into the bloodstream. This insulin stimulates the liver to convert the blood glucose into glycogen for storage. If the blood sugar goes too low, the pancreas releases glucagon, which causes the liver to turn stored glycogen back into glucose and release it into the blood. Near normal levels of blood glucose and blood pressure, as well as lipid control, are essential for preventing diabetes-related complications and improving the patient's quality of life. In the short term, hyperglycemia causes symptoms of increased thirst, urination, and hunger, as well as weight loss. In the long term, hyperglycemia causes diabetic complications, including retinopathy, damage to the eyes leading to blindness, nephropathy, kidney damage leading to renal failure, and neuropathy, damage to the nerves leading to impotence, pain, and foot disorders, possibly leading to amputation. The primary metabolic disorders discussed in this chapter are as follows. Type 1 diabetes mellitus usually develops in childhood and adolescence. Patients require lifelong insulin injections for survival. Type 2 diabetes mellitus usually develops in adulthood and is related to obesity, lack of physical activity, and unhealthy diets. This is the more common type of diabetes, representing 90% of diabetic cases worldwide. Treatment may involve lifestyle changes and weight loss alone, oral medications, or even insulin injections. And then hypoglycemia. This is a common problem with people who use insulin. Hypoglycemia, or low blood sugar, is the most severe acute complication of insulin therapy in diabetes. This is Table 13.1. These are the characteristics of type 1 and type 2 diabetes mellitus. Patients with type 2 diabetes mellitus are often initially treated with diet and exercise for glycemic control. With management of type 2 diabetes, when hyperglycemia cannot be managed with diet and exercise alone, patients may be prescribed oral anti-hyperglycemic drugs, injectable insulin drugs, or insulin, or a combination of these drugs. Anti-hyperglycemics, also known as biginuides. Biginuides are the first-line medication for the treatment of type 2 diabetes mellitus. Metformin is a biginuide anti-hyperglycemic agent that works by doing the following. It decreases hepatic glucose production. It decreases intestinal absorption of glucose, and it improves insulin sensitivity by increasing glucose uptake and using target sites. Metformin is an oral medication that is generally well tolerated. Common side effects include diarrhea, nausea, and abdominal pain. Insulin secretologues. Insulin and insulin secretologues are known to cause hypoglycemia. This medication class works to do the following. It stimulates insulin release from the pancreatic beta cells. It reduces glucose output from the liver, and it improves insulin sensitivity at the peripheral target site. Patients should not take this medication if they are not going to eat a meal due to the risk of hypoglycemia. The effect of this oral medication generally begins within a half an hour of administration and can last for up to 24 hours. Common side effects include nausea, diarrhea, low blood sugar, headache, sleepiness, skin rash, and shakiness. A sodium glucose cotransporter 2 inhibitor. This is a predominant transport response for reabsorption of glucose from the glomerular filtrate back into the circulation. The popular oral medication is an inhibitor. Like all diabetes medications, we should use this as an adjunct to diet and exercise to improve glycemic control and reduce the risk of cardiovascular death in adults with type 2 diabetes mellitus. There is a dehydration risk that is compounded if a patient is taking hypertensive prescription medications. Glucagon-like peptide 1 receptor agonists. These medications control through several mechanisms, including enhancement of glucose-dependent insulin secretions, slowed gastric emptying, and reduction of postprandial glucagon and food intake. This medication, also known as Trulicity, is recommended as an adjunct therapy to the first-line agent metformin therapy for patients who have inadequate glycemic control with diet and exercise regimens alone. People living with type 1 diabetes mellitus always require treatment with insulin, and many people with type 2 diabetes mellitus eventually require insulin therapy as well. Insulin is destroyed in the GI tract and must be administered by injection or other perienteral routes. Insulin replacement in people with type 1 diabetes mellitus should ideally mimic pancreatic beta cell function by providing basal cell and prandial requirements, the physiological replacement. This approach requires close attention to diet and exercise, as well as to insulin timing and dosage. When insulin is needed for patients with type 2 diabetes mellitus, glycemic control can often be achieved with combination of basal insulin and non-insulin anti-hyperglycemic drugs, although prandial insulin may be needed in some patients. Human insulin preparations are commonly categorized by their time to onset and duration of action. However, these parameters vary within and among patients depending on many factors, such as the site of the injection, the technique of injection, the amount of subcutaneous fat, and the blood flow at the injection site. All forms of insulin have the potential to produce hypoglycemia or insulin reaction as a side effect. 4 insulin types are classified by the length and peak of action, including short-acting, rapid-acting, intermediate-acting, and long-acting insulin. Rapid-acting insulins. These insulins are rapidly absorbed and often begin to reduce plasma glucose within 15 minutes, but have a short duration of action, usually less than 4 hours. They are best used at mealtime to control postprandial spikes in plasma glucose. These are typically inhaled regular insulin. It's a newer rapid-acting insulin that is taken with meals. Short-acting or regular insulin. This is also known as human insulin. It has a slightly slower onset, typically 30 to 60 minutes, but lasts longer, 6 to 8 hours. This is the only insulin form for IV use. After subcutaneous injection, it leads to more rapid absorption into the circulation. Intermediate-acting insulin is also known as NPH and has an onset action of about 2 hours after injection, with a peak effect about 4 to 12 hours after injection, and the duration of action about 18 to 26 hours. Long-acting insulins have no discernible peak of action and provide a steady basal effect over 24 hours. Pre-mixed combinations are commercially available in a pre-mixed preparation. This is figure 13.1, illustrating different types of insulin and their duration of action. Insulin dosing regimens and delivery doses. Insulin dosing regimens closely simulate the normal pattern of insulin secreted by the body. The first method is an insulin pen. There are many different pre-filled insulin pen injection devices. These are available as alternatives to the conventional vial and syringe method. Insulin pen injectors may be used away from home and may be preferable for patients with limited vision or manual dexterity. These are spring-loaded, self-injectable devices. These devices are injected into the subcutaneous fat. An insulin pump is a continuous subcutaneous insulin infusion method that uses an insulin pump. This is a small device, often the size of a pager, that's worn on the belt or on the clothing, with a thin plastic tubing coming from the pump to a needle that penetrates the skin, usually on the abdomen. It's in place 24 hours a day. This is as close as one can get to the constant gradual administration of insulin that is taking place in the body. With this method, the basal insulin requirements that are met by the continuous infusion of the subcutaneous insulin. The rate of which insulin is administered can be varied to accommodate diurnal variations. The computer-operated pump delivers one or more set of basal amounts of insulin. In addition, a bolus amount of insulin may be delivered when needed by pushing down on a button. Insulin pumps are becoming increasingly popular among the physically active population. Infusion pumps can eliminate the need for multiple daily injections, providing maximum flexibility in the timing of meals and substantially reducing the variability in glucose level. The disadvantage includes the cost, mechanical failures leading to interruptions in insulin supply, and the inconvenience of wearing this external device. This is figure 13.2, using an insulin pen injector, the parts of the insulin pen, and the insulin and common insulin injection sites. This is figure 13.3, a basic insulin pump with a glucose sensor and infusion set. Each type 1 diabetic patient must follow an insulin and dietary management suggestion in conjunction with exercise. Adjustments to insulin administration are necessary with exercise to prevent hypo or hyperglycemia. A hyperinsulemia state with inadequate caloric intake can lead to hypoglycemia during or after exercise. Thus, prior to exercise, Athletes with type 1 diabetes should reduce their exogenous insulin by 20 to 50%, depending on the intensity and duration of exercise. Consistent exogenous insulin administration can be achieved through an insulin pump. The pump administers continuous insulin via a subcutaneous catheter. Removing the pump for exercise requires adjustments in insulin timing and administration. The proper management of blood glucose levels during practice and games allows the athlete with diabetes to compete in safe and effective manners. Maintaining a near normal blood glucose level between 100 and 180 milliliters per deciliter reduces the risk of dehydration, lethargy, hypoglycemia, and autonomic counter-regulatory failure. This goal is best achieved through a team approach to providing support for patients with diabetes. Specifically, our plan should include the following: addressing frequency of monitoring and pre-exercise exclusion values, insulin therapy guidelines, including the type of insulin used, dosages and adjustment strategies for planned activity types, as well as insulin correction dosages for high blood glucose levels. The list of other medications include those used to assist with glycemic control or to treat other diabetes-related conditions. The guidelines for hypoglycemia recognition and treatment include prevention, signs, symptoms, and treatment for hypoglycemia, including instructions on the use of glucagon. The guidelines for hyperglycemia recognition and treatment, including the prevention, signs, symptoms, and treatments for hyperglycemia and ketosis. The emergency contact information. This includes telephone numbers for the patient's parents and other family members, physician's telephone number, and consent for medical treatment, especially important for minors. And finally, the identification. Athletes with diabetes should have a medical alert tag with them at all times. Managing hypoglycemia. Hypoglycemia is the most severe acute complication of intensive insulin therapy in diabetes, and exercise is the most frequent cause. Mild hypoglycemia is a blood glucose level of less than 100 milligrams per deciliter, whereas severe hypoglycemia is a blood glucose level of less than 70 milligrams per deciliter. Both require action according to the diabetes care plan to bring it back into a target range. Under most circumstances, hypoglycemia is the result of a patient skipping a meal or a snack, eating less than usual, or being more physically active than usual. Athletes with type 1 diabetes who have achieved superior levels of performance have established patterns of carbohydrate feedings and insulin therapy that work for them. Individuals experience and trial and error with manipulations of diet and insulin administration must occur if such an athlete is to establish reliable glucose control. In the cases of severe hypoglycemia, an intramuscular injection of glucagon remains the preferred method of treatment. The athletic training staff should be familiar with athlete-specific symptoms of hypoglycemia and be prepared to act appropriately. This is Table 13.3, the treatment guidelines for hypoglycemia. In patients with type 1 diabetes mellitus who are insulin deficient and ketotic due to missed or insufficient insulin, hyperglycemia can be worsened with exercise. However, very few people with type 2 diabetes mellitus develop such a profound degree of insulin deficiency. High-intensity anaerobic exercise is frequently the cause of dramatic exercise-induced hyperglycemia and places a theoretical risk of exercise-induced ketoacidosis on the patient with inappropriately low basal insulin concentrations. In the patient with diabetes, this process often leads to hyperglycemia, but the normal secretion of insulin provides a rapid reduction in blood glucose. For the patient with diabetes, high-intensity exercise performed until exhaustion, typically at 80% of maximum oxygen carrying capacity, This often leads to elevated blood glucose levels after exercise that remains high for significantly long periods of time, longer than those for control subjects without diabetes. Therefore, people with type 2 diabetes generally do not need to postpone exercise because of high blood glucose, provided that they are feeling well. People with type 2 diabetes may engage in physical activity, using caution when exercising with blood glucose levels greater than 300 milligrams per deciliter without symptoms of ketosis, provided that they are feeling well and are adequately hydrated. Athletic trainers and the diabetes management team must have a plan. We need to have a plan in place to treat both hypo and hyperglycemia, and we need to be familiar with glucagon administration. We need to read the NATA position statement. It would be good to be familiar with the ACSM and the American Diabetic Association position statements regarding diabetes and disordered glucose metabolism as well. Athletic trainers should be familiar with different medications indicated for diabetes treatment. We should be familiar with different applications and drug-drug interactions associated with diabetes medications. Exercise is beneficial for individuals both with type 1 and type 2 diabetes, but we must understand that some precautions are needed as well.